So the following expert is from a CPD event that we held on the 28th of November 2023, and we covered aspects of how do we sense pain and how do we assess pain. Some of the other elements that has been discussed, I took out, so I hope you can learn some of this activity that we had and the information that we presented. I hope you enjoyed.
Mr. Elroy, okay, thank you. Thank you for that. Anybody there would just like to give us an overview of this slide? I think this might take us about 2 hours just to run through that. But nonetheless, I've got a bit of a more simpler one that I would like to share with you, and that it won't take up all these elements, because remember how we sense pain and the entire pathway to getting to, hey, I've got pain in my finger or wherever that may be, is actually a very complex situation. So a more simple version of that is the keys. There's a couple of stages of this pain. So the first one that we're looking at is the transduction. Now, what that basically means is that painful stimulus, and literature refers to it as the noxious stimulus, gets changed into an electrical signal. All right. And then that follows up to transmission. Transmission, that electrical signal then moves along all the various tracks, nerve tracks, until it reaches the brain. And perception, now that is the part when that nerve signal crosses over to the somatosensory cortex, and then we will know that we have pain. Modulation, that happens generally anywhere in all of these tracks, and modulation is basically the blunting of pain. So if you think about a highway, a lot of vehicles moving up and down, if there's a traffic cop that stands somewhere on the highway, slowing traffic down. So this is basically what modulation does. It slows these signals down and slows these activities. Now, this can happen, as I said, anywhere on these nerve tracks. So there you can just have a quick look at our noxious stimulant going through the transduction, through the transmission, up till the point of perception. All right. And this happens tremendously fast. It's not a very slow process. And you will know if someone knocks a hammer on your finger, you'll know immediately that there's pain. All right. But now here's the thing. We've probably heard a lot that pain is subjective. Anybody heard that statement before? Just a raise of hand quickly, someone? All right. Tennis. Could you share us what do you understand about that pain that is subjective? If you just quickly would like to unmute for us for 1 second. Is it perhaps in, I think I saw Sandile. Could you perhaps just share quickly with us? Okay, so not to delay the process. Now, the subjectivity of it is basically what it says. So I can have an injury, and another person next to me can have, let's say, pain. Sorry, not an injury, pain. And I might say this is excruciating pain. And for another person, it is, almost like a little pinch. And this is where we as a practitioner, we can't gauge that level of pain between the two persons. Say, for instance, you're driving your vehicle at 120 kilometers per hour, and I drive at 119 kilometers per hour. Because the speed is so close to each other, it's somewhat a bit hard for us, especially for someone from the outside of your vehicle, to perceive exactly that speed. Well, obviously, there's calibration issues as well, but that's not really what we want to talk about. But this part of perception, this is what makes it subjective from our point of view. And if we look at two patients when they actually, you know what, I have a high pain and I have very, very little pain, right? So, is there any questions up till this point? And if I'm moving too fast, please just let me know so we can slow down. Just raise your hand or put in the comments. Mr. John, you monitoring the comments there?
Yes, I'm monitoring the comments.
Okay, all right. Okay, so if this, I assume the pace is okay, it's not too fast. All right. So moving on to the next slide, this is Samson. Yes.
Okay, I don't know if maybe I understand it correctly on the subjected pain. Is it subjected to the object impact, or I don't know, I was just thinking the more the impact, the more the pain, or
okay. So basically what we're talking about is when we measure the pain, when we assess it. So I take, for example, I'm going to read a blood pressure. You know, I put on the blood pressure cuff, I take the blood pressure, and I get a reading of 120/60, for instance. So I've got a concrete level or, you know, a blood pressure. Let's say the next practitioner comes along, does the blood pressure, and, you know, within a given a variance, he might get 122/62. So it's fairly close, right? So we have an objective sense of what the person's blood pressure is, all right? But now when we look at this situation of pain, for instance, you know, you get this new drink. It's a very strange color. I think it's a Fanta. It's a weird color. And then I believe there's a competition on it. And then they ask you, what flavor is it? So it might look like Coca-Cola, but it tastes like orange. Now, some people have their own perceptions about, you know, about what it is. So it is how they perceive it. But we're not discounting that that is real to that person. So for me, like I said, the pain is high. The person next to me, the same type of stimulus that that person might get is a very low level of pain. So now we start thinking of things like pain thresholds. So some people can withstand a lot of pain and others don't. I hope I answer your question there, Mr. Sampson.
Yes, sir. Yes, sir.
Okay, thank you so much. Right, so moving on to our next slide, pain situation. Now, we are going to look at pain assessment. And I would like to ask anyone in the audience who's willing to share an experience or what do they do with regards to assessing pain.
Thank you.
Spot on. Thank you so much, Sandila. I really appreciate that. And as we move into our pain assessment, let's look at a couple of considerations or things that really impact our assessment. And you are absolutely right. Sandile mentioned age, and age is one of them. And we also have cognitive ability. So there is a close link between them. They are linked, and they can also be unlinked, if that makes sense. You can have a child that is 3 years old, for instance, and their cognitive ability we would expect to be at a 3-year-old level. But cognitive ability can also refer to, let's say they have some previous brain injury or some other sort of mental challenge, and that will also impact their cognitive ability. Now, you as a healthcare provider, now this is going to make your assessment quite a bit more challenging. Other things that we're looking at is injuries, illness, past medical history, physiological aspects, the person's emotion at that given point in time. We can even look at the environment or the situation. These are just a couple of things. There are numerous, but there are many more we can consider, and that will impact the patient at that given point in time. All right. So let's look at the following slide.
someone explained that sometimes the children, they don't actually cry or react or do funny things when they have severe pain. The clarity, especially when you're talking about the age and cognition.
Yes, 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 yes. It's possible. Many people, I'm sure you've seen them as well in very difficult situations that um, it looks bad, but they're lying very patiently and quietly waiting. So remember, when you're also having a traumatic event um, of that nature, remember your body, and this is a part of those lot of chemicals and stuff that I haven't mentioned. A lot of these chemicals actually get released. Remember, you've heard of the flight and fight response. You get that, plus a whole bunch, a cascade of numerous releasing of chemicals, hormones, and you also get the blunting, as I mentioned earlier. So all of these factors play a role, and that's why the whole pain aspect is such it's actually a very complex process. I mean, if you have time, just open up a textbook, and it will take you first to a chemistry class before you get to the anatomy and physiology class, just to understand all those things. And you will have that blunting for a moment. It is absolutely, absolutely possible. Um, I don't know if Elroy would like to mention anything here.
No.
Yeah, Mr. Carolus, and I want to come in with a social cultural consideration when you assess pain. So some cultures, if you are a man, you don't have pain. Like they say, men don't cry. And in my experience, I've seen similar types of injuries where one person will say, fractured femur, no, I will stand up and walk home, because in the culture is, if I show pain, it's weakness. Where in other cultures, the guy's finger might just be cut and he will be like, oh, I'm going to die, I'm going to do this, I've got so much pain. And that's where we as practitioners need to come in and look at also the social and culture aspect of assessing pain, because we can have some sort of idea. If it's a fractured femur, that must be very painful compared to a cut finger. And if this person is saying, I don't have pain, that there comes in the perception again of what you perceive as pain and how you will see it in your culture and in your social aspects of things. And even your cognitive ability, if the person is under the influence of any substances or anything like that, he will be not able to tell exactly what type of pain he has, or he might exaggerate the pain. So there's all other factors that you need to take in consideration. Just wanted to say that.
All right. Thank you. Thank you so much for that. All right. So let's go on a pain assessment tool. And it's one of many. It doesn't need to be the only one. And I think most will be actually very familiar with the OPQRSTA, where O is the onset, when did the pain start, provoke, P, what triggered it, what made the pain worse, quality, and we're looking at is this a burning pain, a crushing, or a heavy pain? Radiate, does the pain spread anywhere, or is it just localized to one area? And severity, is it a low pain, or is it very, very bad? Timing, does the pain come and go, or is it is it a constant pain? And any factor that may alleviate the pain. So some people might say, you know what, if I keep my arm like this, then that helps a bit with the pain. And during your management, I like to chase that specific alleviating factor if it is present at given the situation, because that gives me a little bit of time to do some other things. Perhaps you sit with 3, 4, 5 patients, maybe more. So if an alleviating factor is there, do take profit on that factor. So if we just look at that severity, the score 1 to 10. Now this is that perceptive, that subjective point of the patient's point of view. I score this as a 7. and the patient next to me scores whatever the pain is 5 perhaps. So this is one method of many, and I'm not saying this is the one that you should be using, but I think most of us will be familiar with this pain assessment tool. So our following pain assessment tool basically covers a lot of things. Now this is the Socrates, this is not the philosopher, but what this Socrates assessment adds is things like the sight, and that's pretty much most of the what it adds, as opposed to the OPQRST. So very similar things that they do ask, just in a very different way. So I would say use what you're comfortable with, what you've been using for all this time, and whichever is makes sense to you. All right, so that just covers a couple of our pain scales. Now let's look at Wong-Baker pain rating scale, also a very common one, and this is pretty much where the severity comes in. Okay, this is one rated from 0 to 10. Now Wong-Baker, the faces are generally what they use for children, and then they have the numeric numbering system, the 1 to 10, which they generally use for adults. Now, a lot of studies has been done around this, using different pain rating scales, comparing to each other, and this is that whole subjective thing that we're talking about. Now, obviously, one of our participants mentioned you look at the the facial expression, and there's number 10, the facial expression. So it's not very likely to be happy to have pain.